Thank you for inviting me, but I do want to point out that I represent neither the federal government nor any foundation, and therefore I'm not going to show any slides because that would lead you to believe that I'm informed, but in fact I'm not. So I'm going to offer some random thoughts. Nobody spoke to me. I accepted your invitation, and I realized when I sort of looked over your prospectus this morning that I didn't know why I was on the panel or what I should say. So therefore, I'm going to offer random thoughts, but they do relate, in fact, to lifestyle. I want to start by reminding you of the World Health Organization's projection as to what percent of our longevity is due to several entities. So the WHO says that 40% of our longevity is due to the social determinants of health, that 30% is due to our individual behavior, that 20% is due to our DNA, and 10% is due to whether a doctor does a good or an evil thing for us. So that 10% is very sobering to our medical students, since they really thought they were at 100%. But it's an important set of statistics, I think, as an aside, that the 20% due to our DNA is an undercall, and the more we do deep sequencing of the genome and the epigenome, I think the more we have to recognize that the contribution of our DNA to our longevity is probably considerably greater than 20%. But in any case, because we're talking about lifestyle, I want to dwell a moment on what I believe there is about lifestyle and social determinants that influences our health, often in revolutionary ways. Recently, I heard a talk by Zanny Mitten-Beddoes, the wonderful editor-in-chief of The Economist, actually the first woman in 100 years to edit The Economist. But she talked about the 5 global shocks that we are currently confronting. The first being the shock of big and collated data and all that it means with respect to artificial intelligence, machine learning, random forest ensemble, statistical genetics, issues of privacy, etc. So the data shock. The second shock that she described was the shock of shifting manufacturing to high technology and its consequences for the economy and in particular for income inequality. The third shock she described was the demographic shock, the fact that we have these massive waves of nationalism, populism, and immigration that are now worldwide. The fourth shock she described as geopolitical, and that is the extraordinary ascendancy of China, and to some extent, the slowing and in some ways the diminution of our country as it marches pari passu with China. And finally, of course, the shock of the climate. And so one might say, confronting these 5 global shocks, that many of us are paralyzed. And that's where I think we need to think about how we are to live our lives. Are we going to be paralyzed? This seems like a tremendous burden, an existential burden. Data, high technology, immigration, China, climate control, etc. How would we ever get through this? Now, one way we can do it is to compartmentalize. We can spend 2 days talking about the specifics of our particular areas of interest, and that might protect us from breathing in the face of these shocks. But in fact, we've done it before. We've had the Industrial Revolution. So think for a moment about the Industrial Revolution. The Industrial Revolution had as many shocks as the shocks we're confronting now. We certainly shifted from agriculture to manufacturing. It had a an extraordinary economic impact. We had waves of immigration. Think of all of the Eastern Europeans and Central Europeans who came to Pittsburgh to work in the mills. We certainly had a geopolitical shift. Think about the ascendancy of this country. And finally, at least in Pittsburgh, we had a problem with climate control because we had to turn the streetlights on at noon because the air was filled with smoke. But we got through it. We survived the Industrial Revolution, and perhaps I'm an inveterate optimist, but I believe we will survive the 5 shocks that I described. I've mentioned this because it clearly has an influence on how we live our lives, our individual lifestyle, and particularly the lives we live as the members of a society and of a culture. And that would lead me to think about the implications for healthcare, particularly in our country. So we're now spending between 18 and 19% of the GDP on healthcare. The rest of the developed world spends between 8 and 9%. Our outcomes in general are worse than the rest of the developed countries. And the cost, as I said, is extraordinary. So we're paying a lot of money. We have poorer outcomes than we should have. We have less quality control than we should have. And we certainly have less access than we should have, although that's improved a little bit with the Affordable Care Act. In any case, it's interesting that virtually none of this money that we do spend is spent on prevention. If there were ever an entity that we should be pursuing, it's how to prevent disease rather than treat disease. We have the best model here in Pittsburgh. When Jonas Salk developed the polio vaccine, and it put to bed the iron lung. The iron lung cost, normalized to current dollars, millions of dollars to imprison a child for a limited life. But now for pennies, we can immunize against polio in most of the world. So if ever there were an example of the value of prevention as opposed to treatment, that's it. So we have an extraordinary challenge now, and it relates very directly to how we live our lives and how our society lives its life, particularly since, although we talk a lot about health insurance and we are engaged in spirited debate about Medicare for all, et cetera, the fact is that 65%, almost 70% of health care is insured by the federal government. Medicare, Medicaid, CHIP, the Children's Hospital Plan, the Affordable Care Act. Think about it. You'll all remember the pictures of seniors parading outside of Boston with posters that said, "Keep the government out of my health care," when they were all on Medicare. So the fact of the matter is that we're about to face, over the next year, a presidential election, a possible change in administration that will have profound impact on our health and the economics of healthcare. And there's no way that we can consider our lifestyle without thinking about what the implications of that will be. Finally, I probably should say a word or two about what I was asked to talk about, which was the federal government. So I'm not a Fed. I spent 31 years at the NIH. I started as a postdoc. I was one of the Yellow Berets. I was given a chance to go to Bethesda instead of Ho Chi Minh City. And I was tenured in my third year as a postdoc because I had a lucky break in research, and ended my 31 years as the scientific director of one of the institutes before coming here. So I now have a 50-year-long view of what health, medicine, and contemplative philosophy should offer us. But I have stayed close to the NIH. And 2 years ago, I was asked by Dr. Collins to chair the Blue Ribbon committee that was to draft the next NIH strategic plan, which was called Advancing Biomedical Research in a Data-Driven Era. I was the only member of that committee who was not a Nobel laureate or a member of the National Academy, I probably was chosen for that reason because they couldn't decide which Nobel laureate to choose, so they had to give it to the one member of the committee who was neither. And I did chair that committee. I have some pride in the draft that we produced, and that's brought me, once again, reasonably close to the feds. So, I'm sorry, what's the NIH going to support over the next several years? And I think that is a way of distilling much of what you've heard about. First of all, the NIH's money is going to go to the following 4 activities. First, I would say precision medicine, and you've heard a lot about all of us from Steve Reese and others. I think that precision medicine is informed literally by the moment by deep sequencing and by the application of artificial intelligence to deep sequencing. I think, thank you. I think that the implications are profound. You may have seen in the New York Times a day or two ago the momentum in China to translate sequencing to facial recognition. And so when you think about the implications of that, it's profound. Secondly, with precision medicine in hand, we now have the challenge of editing the genome. And you probably all know about Dr. He in China and his editing 2 twin embryos with the goal of preventing HIV, totally unnecessary because it's a lot easier and safer to prevent HIV in infants other than off-target editing of their genomes. But we do have CRISPR-Cas9 and even newer variants of CRISPR that are less off-target, and so the promise of genome editing is extraordinary, but so are the ethical dimensions of editing the genome. So the third area that the NIH is going to put a lot of money into is the brain, and in particular, neurotechnology. We now have extraordinary papers describing the use of optogenetics in the living brain. We have extraordinary papers describing single-cell resolution in real time at the nanoscale. We have examples of using CRISPR in animal models to replicate human neurologic disorders. And we have many papers that are combining cell and molecular biology, electrophysiology, structural biology, computational biology, and in particular engineering to further understand the structure and function of our brains. The fourth entity that the NIH will put increasing amounts of money into, of course, is cancer immunotherapy. And I would expand beyond that to talk about the role of immunology and inflammation in general, but especially our recognition that, and I think you may have heard about this, the notion of T-cell exhaustion, the fact that T cells infiltrate tumors, and yet they don't work. They don't work for a number of reasons, but the main reason is that they become tired and exhausted, and the tumor cell itself sends out a signal to exhaust the T cell. We even see this in lupus nephritis, interestingly enough, an autoimmune disease where we would expect the T cells in the kidney parenchyma to be hyperactive, but they're not. They're essentially dead. The T cells, there's something about the kidney parenchyma that suppresses the immune response of T cells in lupus nephritis. So there are lots of interesting connections now between cancer immunology and autoimmunity, and the NIH is going to put a great deal of effort into this area. So let me finish just by saying that we talked a lot about big data and artificial intelligence, machine learning. I think there's been a fair bit of discussion about imaging. I would point out that we now can go from the nanoscale in 3 dimensions with tomographic cryo-EM, where we have just installed our machine here, all the way up to functional MRI. The folks in psychiatry can tell you what somebody is thinking about, learning, memorizing, whether they're happy or sad, all with functional MRI. So I hope that's given you a little bit of thought about some of the things that I'm thinking about and some of the things that I think Francis Collins is thinking about. Thank you.
Thanks, Dr. Levine. Eduardo, do you want to stand up here, or do you want me to do them for you?
I'll stand only because
okay.
I'm
Got you ready to go. Yeah, you're a mover.
ADHD kid.
You got a couple slides.
This has been a great couple of days, and I'm going to try to be really quick, sort of laundry listish. But the American Heart Association, American Stroke Association is the organization that I work for. I serve as the Chief Medical Officer for Prevention. And I want to say that because it seems to me that I'm in the right place given my title. And my focus is on the upstream stuff that, when not taken care of, leads to the kinds of things that the American Heart Association, American Stroke Association takes pride in having done over the last almost 100 years. We are a heart and brain health organization, and I want to make clear, I think I said American Heart Association, American Stroke Association, but that's too many words, so we just say AHA. We work closely with the American College of Cardiology, and one of the things that Kim Williams talked about was this, but we do lots of joint guidelines. This is one that is upstream. This is about primary prevention. Most of our guidelines are about when bad things happen to people and they're in the hospital and need to be taken care of. We're known for CPR, we're known for AED work, and we're known for ACLS. We're the second largest funder of CVD stroke research in the United States. We funded last year $180 million of research. And that may sound like a lot, but let me put it in context just a little bit. The NIH 2019 fiscal year budget was $39 billion, and NHLBI budget was about $3 billion. So if we're just looking at heart disease and stroke by considering NHLBI as being representative, that's about 7.7% of the NIH action. And AHA is about 6% of the NHLBI action. So it's a small sliver, but we think it's an important sliver. I would be remiss if I didn't say that 20+%, maybe 30% of the disease burden is cardiovascular disease and stroke related, is in that realm of lifestyle. And we would argue, or maybe debate with anybody, that we're not focusing on the things that are affecting the health of America to the degree that we should with NIH funding. With that $180 million, we focus on early investigators. We focus on underrepresented race and ethnic group scientists. And we emphasize in our funding the inclusion of underrepresented racial and ethnic group participants and subjects, and have made that a very, very important point of what we do. We have been responsible for helping to fund 14 Nobel laureates. And Brett Giroir, our current Assistant Secretary for Health, is an early investigator grant recipient from the American Heart Association, and really not a week goes by that somebody doesn't come up and say that to me, that they are an early investigator grantee. And that led to the preliminary data that then took them to the place of having a successful R01 submission. We're directionally moving to more population research. So moving to community cardiovascular risk factor kinds of research and social determinants. I mentioned the prevention guideline. There's a couple of things there that I think are really positive things. One is movement towards plant-based diet. Cautionary messages about trans fats, processed meats, salt, and sugar. And I think directionally, AHA has moved to a direction and in a place that one might not have predicted in the past, Kim's comments notwithstanding. There's physical activity recommendations, highly influenced by the National Physical Activity Guidelines, and of course tobacco. Relevant to our conversation, we have had discussions at the American Heart Association about taking what we call Life Simple 7. They're characterized here. Life Simple 7 is AHA's definition of ideal cardiovascular health: not smoking, healthy eating, physical activity, healthy weight, healthy blood pressure, healthy blood cholesterol, healthy blood glucose, and have thought about making it Life's Essential 8, and number 8 being sleep. We feel like the evidence base is there, that maybe it's time for that to be incorporated. But again, I think I would echo what Kim Williams has to say, which is that perhaps we ought to be expanding the things that we are commenting on in our primary prevention guideline in particular, to say there are some psychosocial issues that ought to be incorporated into how we think about things. We do have a precision medicine platform. It's a big data and merged data platform. It is about data curation, but maybe more importantly, we are trying to figure out how we can create the right data scientists for the world that we are emerging into. And the conversation we're having today has to include not only that we have big data, but who's that workforce that's going to be doing the analytics that we need to have done. We do work in the work health space, 45 or so Fortune 100 companies, and I think relevant to the conversation we've had in the last couple of days, that CEO roundtable has moved to the AHA to, moved is the wrong word, expanded our view of things to where it started with a focus on Life Simple 7 and now has included a white paper on resiliency and a white paper on mental health in the workplace. I'm going to focus on two more things, very relevant. The American Heart Association has tried to change how it does some of its funding, and we've established these things we call strategic focused research networks. They're very large, cross-disciplinary, basic science, clinical science, population science, all needs to be incorporated into the proposal, looking at the etiology, pathophysiology, treatment, prevention of disease. These are synergistic research projects, generally, but not necessarily intramural. They are ROI-like. 3 to 5 research centers with 4 years of funding, about $4 million a year, so $1 million a year, with one oversight advisory committee, and we have funded a number in these focus areas: prevention, hypertension, disparities, women's health, heart failure, obesity, children, vascular disease, atrial fibrillation. The newest one is cardiometabolic disease. And what I would say to you is that if I were to list to you what some of those research projects have been in the institutions, you will find that lifestyle medicine is part of what is in that huge portfolio. One of the other things we did, we announced in scientific sessions, we are dedicating $20 million to be set aside for vaping research, basic clinical population, particularly focused on what's going on with children. You may or may not know, we understand that nicotine is addictive. We don't know how to get children who are addicted to nicotine off of nicotine. So we don't have the treatment therapies or treatment guidelines out there. And then last, I'm going to put this slide up and just say, you know, lifestyle medicine, I think we're at the place that we generally know what we need to do, but this summit, I think, is about knowing how to get it done, not only the research to inform that, but also how you take the findings of that research and translate it into action, which generates another level of research, which is the translational implementation science research to help us understand how we do the deployment, the implementation, the translation better in an iterative way. So here's a slide with some things going on. In parentheses are bodies that are already doing some of this work that I think informs the work that we want to do. And I would add to this list, I was glad to hear Health Services Research mentioned earlier, value-based design, benefit design research, I think is an important thing for us to do. Cost-effectiveness research, can't say enough that we've got to do that work. We've got to be able to say this is the value proposition. But let me say one thing, cautionary tale. Let's not talk about saving money. Let's talk about better use of money, because isn't it better to have somebody not get a disease, even if you had to invest X amount of dollars, than to salvage somebody who got sick and spent X amount and spend the same amount of money? And we've got to figure out how we do that. Last thing is that I think this conversation has to include research that's done on a population level and begin to look at the intersection, the interaction of clinical intervention with community intervention, and what does that interaction look like? What's the right combination for a variety of things? They're not all the same. There was a comment made earlier about we don't need to do tobacco in clinical care settings. At least that was my interpretation. I don't agree with that at all. I think that the environment that we live in now in many communities, saying to a patient, are you ready, asking a patient, are you ready to quit? And then going down a motivational interviewing pathway is a way to get the patient to perhaps say yes. Then we use the clinical tools that we can use to help that patient, and then they may and hope that they are living in an environment where there's no smoking, where in the workplace not smoking is encouraged, and all of it reinforces the thing that we were trying to reinforce clinically, and I think that model can be one that's replicated for all the things that we've talked about in the 6 domains.
Thank you for inviting me. I want to say that I was thoroughly impressed with all the speakers and the hospitality. Everybody's so friendly, and I was really happy to come. I want to make sure that I am brief because of the time. It's hopefully in 5 minutes I can finish what I have to say about this one slide, which is basically we do lifestyle medicine in the armed services. This slide here is from the chairman of the Joint Chiefs of Staff, and our organization is very complicated, but the chairman of the Joint Chiefs of Staff is the top of the military, works for the Secretary of Defense. There are 8 domains there you see on that slide, and essentially are very similar to what you are trying to do here in lifestyle medicine. There are multiple, we'll say, formulations of this that have kind of gone through. This is the direction from the chairman of the Joint Chiefs of Staff, and each one of the services, each one of the combatant commands, each one of the chiefs of staffs of the services has a different way of implementing and executing that. I'm just going to give you an example of 2. So I have several jobs, but one of them is to advise the Combatant Command, United States Special Operations Command, and their program is called Preservation of the Force and Family, POTF. It's actually was probably one of the first ways to see the military doing lifestyle medicine. Obviously, this was probably over 10 years ago under Admiral McRaven, and it received a lot of attention because the colonel that was in charge was a SEAL, and he reported directly to the commander. And that's the biggest point that I'm going to make. And on this slide, you'll see right there on the white, on the bottom, it says, leadership is essential in achieving total force fitness. And I almost could just stop there, because I feel that everywhere I see us trying to do lifestyle medicine, we fail because of leadership. And in the military, we're all about leadership. We are constantly talking about it, and we're trying to train our leaders. But in the bureaucracy that we live in, it's very, very difficult to achieve because, and I'll leave you with this because it applies to a lot of different things we're talking about today, which is if you try to get risk down to 0, you're going to ruin it for everything. You're going to become totally ineffective at what you're trying to do. And leadership needs to understand that. And then the second point I'll leave you with is that you need to reward those people that are able to take risk. And that means that those leaders are only going to get promoted if they're allowed to make mistakes. This doesn't happen today, and obviously you know the political environment that we're living in. It's even more apropos to where we are today, so we're going backwards. And like I said, none of this will ever mean anything unless we understand that principle, because this is a lot of good information, amazing people talking about amazing topics, and a wealth of information, but unless you can execute on what we're talking about, we're going to fail. That's it. Thanks.
Susan, we particularly want to thank you for staying on and over from the DOD, and your passion around that meeting is what made sure that we had you on this panel, so thank you. Steve Woolf.
Well, again, I don't know why I'm here. To pick up a theme from last night, I did work in the federal government at HHS, but at that time Ronald Reagan was president, and I'm understanding that there's a different president now. I'll come back to that in a minute. I found it helpful to hear Dr. Levine's summary of where NIH is going. Not to put a damper on things, but and I think we all know this data, that the remarkable discoveries and advances that have come out of the research supported by NIH and industry research as well has really not worked in terms of improving our health. So we're going backwards in more ways than one, with life expectancy declining in the U.S. and our health outcomes being inferior to the other high-income countries. The probability of a woman surviving to age 50 is lowest if it's an American woman. It's one of the findings from our reports. But anyway, I took as my charge on this to brainstorm a little bit about funding opportunities. I think that's part of what this panel's about. In thinking about the white paper and the research agenda for lifestyle medicine, I think part of the goal of this panel is to think together about where the funding opportunities might lie. Obviously, NIH is an important one, and although we might lament the NIH not giving enough of a priority to prevention or other areas that we think are very important, there has been progress, at least over my lifetime I've seen at NIH, with more emphasis being given to lifestyle issues and prevention than there has been the case before. And in terms of the various research methods we've talked about today, more and more support for doing innovative analytic methodologies of the sort that we've talked about, including predictive modeling and so forth, and NSF as well. I think there's a growing pool of funding from the National Science Foundation in that area. I did want to give a shout out to the comment about community engagement. Community engaged research is a thing now. It has a particular definition, and the themes that were mentioned in the previous panel about respect and mutual support and co-equal partnerships are central to that. And the NIH, I think, has been cultivating some growth in that area through the CTSA grants. So academic medical centers that have CTSA awards are really in a nice opportunity for advancing translational research that might intersect with what we've been talking about over the last 2 days. PCORI as well, Patient-Centered Outcomes Research Institute, is also a potential funding source for the kind of work we're discussing. Health services research was mentioned by Eduardo, and that makes it important to remember ARC. It's not a big player on the scale of NIH, but certainly is a potential opportunity for talking about many of the healthcare delivery models that we've talked about over the last 2 days to give more emphasis to lifestyle medicine. And obviously DOD and the VA are large, including the health services research component at the VA that I think has been very helpful. The current administration, I think, has, and references have been made to this over the last 2 days, has shifted some of the priorities in a direction that many of us might not prefer. For example, the rollbacks in environmental policies that I don't think have been helpful around our concerns about environmental threats to health and well-being. But I think one particular leverage point that the group might want to consider is the role of personal connections, not only with funders directly, so a lot of funding opportunities can be developed through relationships with agency heads or others at NIH and elsewhere, but also through Congress. So members of Congress who have particular interest in some of these issues could be points of leverage in promoting new opportunities for funding. And as a non-Fed, I can say things like that, but that is a particular strategy. We were also asked to talk about foundations. They're an important source of funding. Again, the grants tend not to be as large or as long as an R01 or other kinds of funding sources, but are still important to consider. And those include both the large foundations like the Ford Foundation and other players like that that I think would be interested in many of these issues, but also smaller foundations. I'll just mention one as an example, the Samueli Foundation, which is particularly interested in integrative health and well-being, holistic well-being, and there are other small foundations like that that are important. To harp on a point I've made too many times at the microphone, I'll just revisit it one more time, where I think the current field is, and I think where many funders are, certainly in the foundation world, is not so much on the lifestyle component itself. They're more focused on what kind of changes do we need to make in our communities to make it easier for people to pursue healthy lifestyles. So systems to promote well-being, so Kellogg, Kresge, foundations like that have a lot of interest in promoting the kinds of work that we've talked about around particular theme areas that intersect with your interests, whether it's early childhood or obesity or many others, that I think are potential leverage points for funding this kind of work. The largest health-related foundation is the Robert Wood Johnson Foundation, and the culture of health model that they have adopted for the past few years is really about how do we create an environment in our communities that creates conditions that make it easy for people to make the right choices. So they're the ones with the adage about where we live, work, eat, and play, and so forth. They are very much on the same page in terms of how do we make it possible to promote these healthy lifestyles and remove barriers to that. But I think the federal and foundation perspective doesn't cover the whole waterfront in terms of funding opportunities. So we need to think about novel and maybe non-traditional funding partners for this kind of work. Eduardo's already talked about the importance of professional associations. There's others like the American Cancer Society and so forth that are useful. But don't forget about state and local government, particularly for work that you're doing in your area, where there are entities both at the state and local level that are interested in grants and contracts to support work in this area. CDFIs, an abbreviation you may or may not be familiar with, Community Development Financial Institutions, and local foundations are increasingly interested in this kind of work and have a lot of money that they need to invest to meet their federal obligations. Conversion funds, increasingly in your states, I'm sure you have them, where they are interested in promoting this kind of work. I could go on, but I think there are novel, non-traditional funding partners that should be on the laundry list of usual suspects to consider for funding this kind of work.
Wonderful, Steve. Thank you. Buddy, you want to quote?
So they told me one slide, 5 minutes. I'll do my best here. I'm going to present what we're doing at the VA and argue that it's maybe the best single application of lifestyle medicine at a large integrated healthcare system. To start with the money, the original money for this, when this got started in 2011, and then the money came a little bit later, was from the CARA legislation, which is Comprehensive Addictions Recovery Act. My shorthand for that is anything but opiates. So if we could give a veteran Tai Chi or yoga or acupuncture and they didn't ask for opiates, then we're going the right way. And we've come sort of full cycle. So as of March, which is coming up very quickly, we have to present data from Whole Health to Congress to get more money. So that's first off. Second, my career, I redirected my career, which in Boston means just sending my bicycle a different direction. So I biked 4.5 miles to the VA, and Whole Health is what got me over there, because it was the chance to do lifestyle medicine and hopefully change the world. I'm not a veteran. I'm not related to a veteran. I'm devoted to veterans, but my drive is to say that the VA has produced numerous inventions and things that would then translated into American medicine and can help the world. I believe, and I'm working very hard towards making Whole Health the next thing that we're giving to the world. This material is freely available. It's not designed for veterans necessarily. If you look up Whole Health .wisc, like Wisconsin.edu. There's an encyclopedia that you could read until a week from Tuesday with hundreds of thousands of words supporting all of this. Let me take you through this quickly to point out, because I kept on sitting there like I didn't say things all through here. We have more than 6 bubbles to look at, and specifically, we talk about spirit and soul. Okay, there's a very strong chaplaincy within the VA, and when we start asking a veteran what matters to you, okay, and with a long therapeutic pause that I don't have time for, that's a spiritual question. You know, what are you on the planet for? That was a long therapeutic pause for me. I'm not a psychologist. So, you know, it's like wait for the answer. So spirit and soul around their surroundings. When you blow up that bubble, you get into environmental toxins. The one that just drives me nuts because I'm guilty of it is toxic clutter. You know, do you feel safe at home psychologically? All of these things. We also talk about personal development. So when I present this material to residents, you know, they go like, I'm kind of busy. I go, yeah, you're blowing up the bubble that says personal development. That's what you're about for the next period of time. I'll keep on going quickly. One of the things that drove me, and a question that I have not yet answered, but we're getting there, is there's hundreds of billions of dollars, arguably $2 trillion to be saved when we get the population behaving better. We could just sort of do the numbers. How do you actually collect that money? Who feels it? And I've asked Mike over lunch, like, does UPMC Health Plan does it? Can Kaiser find that money? Arguably, the VA can actually feel that money because we're pretty much a closed system. So when we talk about cost avoidance. So when we get vets doing better things, they tend to ask for less care. And the very, very early unpublished data shows that if you just give them a couple of doses of whole health, they tend to start using less pharmaceuticals, and their month-over-month costs start coming down. We're going to be able to use that money for things that we could not prevent or that are already in the pipeline, and maybe pay the doctor as well, et cetera. And, so who collects that wellness dividend? What do we do with it? So that's the early data. The audience for whole health is the 6 to 7 million vets that are active with us. We also try to roll it out to about 400,000 employees. And then I'm tasked with getting it in front of 122,000 trainees because we want to change the medical care system. So I've got a national role at that, and anyone who wants to help with that, please. I got a lot of folks to go. There's an expression in the VA, it's probably used elsewhere, like never waste a good crisis. So the opiate crisis got us into getting the money because Whole Health stood up and said we can use that money and reduce opiate use. One of the crises that we see now is burnout, and this is the weirdest thing that I could boast. In the VA, only 1/3 of the doctors are ready to quit, which is like tremendous because outside of the VA, it's like above 50%. So I mean, I'm just like so proud that only 1/3 of us are ready to quit. And yet, I get asked to give talks about burnout, and I go in there and talk about burnout, and then I introduce the whole health, and we take the docs, the nurses, everyone, through the process of figuring out how do you these are the key words, how do you make your healthcare personalized, proactive, and patient-driven? We start at the middle of the circle, and we say the me is you. You know, you have to be mindfully aware, what do you want your health for? And then we provide, and we go through each of the circles. I'll tell you, like, this is great. I've shown this to dozens of veterans. I put this in front of one young guy, a recent veteran, and I said, what do you see? And his eyes go around, and he goes, the barrel of a gun. And I'm thinking, now I understand why they mandate suicide prevention training and all VA employees. I'm like, where do we go from here? I go on. Once again, I'm not trained as a psychologist. And I said, what about the barrel of a gun? He goes, I'm going into battle. I want to be fully loaded. I go, what's missing? He goes, that friends and family thing, I suck at that. He said, I need to load that chamber. What do you want to do? I'm going to call my mother. We're making progress here. That's where you want to go. That's where we're going to go. You know, how are you doing with the food? Lovely. We show this to them. We always ask, I'm going to go back to this one more time, what's your mission, what's your aspiration, what's your purpose, what are you here for? We do it through peer support. That's the front line. Another veteran who's gone through minimal amount of training is the best one to talk to the vet. They're not health professionals. Then we bring in the health coaches. My time introducing to this vet could be about 30 seconds because I'm busy. And they came in because their knee hurt, and I got busy with taking care of their knee. It's like a Wikipedia thing. It's not about primary care has to do everything. It's about providing this. This material is freely available. It's being used outside of the VA. And then the last comment I have here, I think, is that the office that runs this, 2 more comments, is Office of Patient-Centered Care, all right, and Cultural Transformation. Until we change every conversation with every veteran, we haven't arrived. The outgoing director of this, Tracy Cadet, and I'll tell you why her leaving is significant, said that if this is just another program, we have failed. But if we change the conversation with every veteran, we find the sweet spot with all of the docs, okay? Why would someone said something besmirching of a vascular surgeon, like they're not, The vascular surgeons love this because they say, we have our patients for life, and we're trying to avoid the neck surgery, right? We're not like those orthopedists. We're devoted to this. The cardiologists love it because it makes their numbers look better if we can get the vets to change their behavior. So we're looking for nothing short of cultural transformation in the VA, and I made a bunch of notes here. So Tracy Godet comes from the integrative medicine world. I think Victoria might have left already. Started this, and now she has moved on from the VA and is setting up a whole health institute with money from Alice Walton and the Walton Foundation. And her charge is to blow whole health into something way beyond the VA and way beyond medicine. And I really think that with all the stuff that we've done here, we need to talk to Tracy. She's, I think, going to have her hands around a lot of money. This is like Walmart money. And that when she's talking about schools, she's talking about permeating the society with this. So I'm done. Thank you very much for the opportunity.
Questions, comments from the audience? Yeah, Michael.
Fabulous. Thank you very much. I think one of the main things to keep in mind with culture change and leadership is who's at the table. And if you want the culture to change, the communities to develop, and the communities to change, thank you very much for pinpointing that. I think that's something that's real and has to be done and can only be done genuinely. Like an advisory kind of thing where they get to look at some pictures and say, yay, that's not really it. And I think that kind of commitment is maybe where leadership, maybe grant proposals, etc., might find some traction. And if you can get those folks at the table and invested, they have people that they can talk to. And those conversations, those are game changers. Thank you very much. I appreciate that.
Just to make a comment about what you just said, trust is absolutely the most important thing. The way that we're doing it in the military is all of these programs, I didn't mention all of them, Task Force True North, we have, I told you POTIF, we have this Total Force Fitness. They're all about embedding providers into the units. Usually it's a physical therapist, occupational therapist, and then the next one would be potentially a human performance coach, and then we have 2 or 3 other people that we can sometimes embed, but it's all about getting them to not travel to the MTF, to the military treatment facility, and get some sort of spiel about what lifestyle medicine is, but instead they're there and they have an injury, or they have a spiritual problem, a behavioral problem, something where they come to someone that they trust. And so we found, and that was through POTIF, that this is the most successful way to deliver the programs. Obviously it costs money, and at least in the Air Force we just programmed $500 million to do that. Unfortunately, with $500 million just in the Air Force, we're only able to do it in certain bases. We got rid of the physical portion, but ultimately what I'm trying to say is that that's the way that we deliver trust, is by bringing the providers down to the unit level.
I just real quickly, I just want to reiterate this point that transformative change, and my sense is that transformative change in addressing healthy lifestyle cannot occur if we stay in our silos. So just academic folks like us talking to each other is not going to get us anywhere. And the most exciting work that you can see going on around the country in moving the needle on healthy lifestyle is coming from collective impact, the term for cross-stakeholder partnerships, where folks come together around the table around common cause to do this. That type of establishing collaborations across sectors, I think is transformative, but it requires us to climb outside of our silos to do it.
So one more thing. We, the American Heart Association, I believe I'm correct in saying this, we're the single largest fundee of the Robert Wood Johnson Foundation. But one of the programs that we are doing that doesn't keep the money with us, I see the Ardmore Institute people looking at each other. I'm pretty sure that's true, but it might be a lie. But the important thing is that, I'm going to tell you, the important thing is that we're passing that money through to communities. And what we're doing is that that money is being used for advocacy and for policy change, which is one of the things that we talked about as being essential to achieve lifestyle change. And one of the specific areas where we have spent some of that money is around sugar-sweetened beverage taxes. And what I want to say is we are not a team of folks who are sweeping in and doing stuff and leaving. What we're doing is engaging communities, spending the time building trust, spending the time establishing relationships, spending the time listening to folks, building competency, capacity, and capability in those communities so that when the handful of folks that were at AHA leave, what's left is a community that now has the capacity to do some of that advocacy on its own. So I think that I just wanted to add that because I think that's part of the spirit here, and we're not going to move the lifestyle needle if we don't engage in a kind of a multi-component initiative to get us where we want to get, in addition to the things that we've talked about today.
Dr. Levine?
I'm not quite sure I understood my fellow panelist preamble about all the money that the NIH has spent and all the research it's done, but the fact that we're going backward in health. Obviously, that's not because the NIH has failed, and in fact, we are, as a society, living far longer than we ever lived before, and as a consequence, we have an epidemic of Alzheimer's disease in this country. The point being that the failure has nothing to do with scientific research. It has to do with the fact that our political, our societal, our economic, and our cultural dimensions are the antithesis of how we should be improving our healthcare. And that, I think, can be traced importantly to how we educate people. I was intrigued with a poll that was published yesterday, a rather large poll of 10,000 people who were simply asked to name the 3 branches of government, and the majority could not. And in fact, 1 out of 5 couldn't name any branch of government. So we need to think a lot about science and healthcare literacy in this country, because until we have a literate and reasonably sophisticated population, I don't think that we can influence the political, the societal, and the economic consequences that I described. I also want to point out that this country is a melting pot, and it's a wonderful melting pot. That's the happy news. Unfortunately, there's a downside, which is that we do not have cultural homogeneity like Denmark and Costa Rica, countries which have far better healthcare outcomes than we do. So our educational challenges are not only as I said, political, societal, and economic, but they're trying to understand culturally how we take advantage of our being a melting pot. If in fact we will still be one, that remains a little bit questionable at the moment. But assuming that we will one day again be a melting pot, or at least more of one, we really have to think about the cultural dimensions behind what we've been talking about. One final comment with regard to the VA. Forgive my narcissistic bias, but UPMC is quite similar to VA because we are a very, very large, fully integrated system. We're an integrated delivery and finance system, and as a consequence, if we can prevent illness, we get to keep the premium dollars and reinvest them back in ourselves and the things that are really important to healthcare. As far as I know, this is the largest on scale integrated system in the country. UPMC is now the largest university-associated medical center in the country. The only other academic center somewhat similar to this is Kaiser, and Kaiser is very, very different than a true academic medical center. So I do want to point out that we've learned a lot from the VA, that in many ways UPMC mirrors what the VA is accomplishing.
The partnership with the VA here is very, very strong. Stephen, the last comment.
Hi, Stephen Wilson with the Department of Family Medicine. So it looks like most people here probably are familiar with the checkbook. That's not always true, depending on the demographic of the audience. But so there's a guy, and he says, "I love my family. They're the most important thing to me." So his friend says, "Give me your checkbook." He opens his checkbook. He sees new shoes, new suit, a new set of golf clubs for himself. He actually doesn't see him spend any money on his wife, doesn't see him spend any money on his kids. And so the point is that if you open someone's checkbook and you look at where their money goes, you know what they really care about. And so I think the funding is really important in terms of bringing in new funding and things. But it's also, I think part of funding is, what do we do with the money that we already have? Where do we apportion that in healthcare? A really small percentage of the money that we have goes towards prevention and lifestyle. So we'll talk a lot about how important lifestyle is, and we'll have a lot of studies that show it. But when it's time to actually put those resources into the population, it doesn't necessarily come out in the checkbook part of it, so to speak. So I think maybe some of the advocacy we could do is internal advocacy, is in terms of how we actually allocate money in health systems and from insurance companies and those sorts of things towards helping populations and people. Having worked a long time in underserved communities, generally my observation is that when times get tight and money gets pinched, we'll close an underserved community health center because they're not profitable. Their profit is usually on the prevention side, or building those relationships so that that person will come back to us maybe after he's had a struggle or fall off the wagon from some sort of drug abuse or incarceration, or return to us with a problem. We may actually impact them on that 10th visit, but that's not profitable. So sometimes the populations that we want to serve the most and really direct our efforts to on the prevention side and lifestyle medicine side, though caring for those patients is oftentimes on the wrong side of the ledger of a balance sheet. And when times get tough, those are the places that get pinched first. So I think we have to think also about, what do we do with the money that we actually have in the health system already? Is that allocated in a way that reflects the values that we expect?
So let's give a final round of appreciation to our panel. Thank you very much, everybody. Very, very much appreciated.